Hello and welcome to another episode of Virtual Global Spine. I want to apologize for being in my truck right now. There's some sort of accident or something, and so hopefully I'll be transitioning to an office here pretty soon. We have Dr. Shaw with us tonight to introduce him. I will just say a few things. He was a fellow when I was a resident and was actually really impactful in my training. And he's heard me tell this before, but when I was a chief and about to go to fellowship with Dan Shuba, he was an outgoing fellow and kind of took me under his wing. I was worried that in our chief year we didn't do a lot of spine, even though we did a lot before that. And he started bringing me over to the spine room really voluntarily and said, why don't we just make sure you're ready for fellowship and you can scrub into the case and, I'll walk you through it and pimp you and everything. And it was awesome. And it was really, really worthwhile actually. And got me ready to meet Dan Shuba. So Jeremy, I've always, and the other thing is today is Jeremy spent a lot of time on the topic he's going to talk to us about. For as long as I can remember, he has been doing studies on infection and probably thought about it and studied it more than certainly anyone else that I know. So I was actually very happy he agreed to give this talk. So without cutting into any more of your time, Jeremy, I'll let you take it from there.
Well, Matt, thank you very much, one, for the invitation, and two, for the incredibly kind introduction. So I've kind of followed this forum, and I think it's awesome, and I'm really thrilled to be able to participate and to talk about one of my most favorite academic topics. So I'm going to talk about post-operative and what I would call problem infections. And we're going to go through a number of cases, and please stop me at any time, use the chat. I'm happy to answer any questions. I do hold intellectual property related to the treatment of infection. I do serve on the medical advisory board of a company called Pergo Scientific that does make some technology relevant to the treatment of infection, and I have options through them. Most of the techniques I'm going to talk about are really well supported by the literature and are considered to some extent standard of care, but definitely constitute off-label use at times. And so those are my disclosures, which actually are relevant to the treatment of infection in this topic. I'm going to give a really small plug for the treatment of infection as prevention. So by far the best medicine in this case at times can be prevention. It is so much easier to prevent infection than it is to treat infection. And by and large, that's management of patient and host factors. For me, this is really essential to success. I think a lot of this is knowing when to say no. This could have to deal with diabetes, obesity, nicotine, malnutrition, whether or not that's paradoxical, substance abuse, and immunocompromise, whether or not that's just functional. This patient on the right-hand side of the screen is somebody who had an elective spine procedure and then subsequently did not do well from this. So my general algorithm for the treatment of post-operative infection, and really any surgical infection in general, is pretty straightforward. And that's surgery, which is debridement. Debridement is not just squirting some water on a wound and wiping around a Cobb elevator. And it really can be quite a bit more involved than that. I may or may not remove hardware, and I'll talk quite a lot about that. Use of antibiotics, either local or systemic, usually both, adjuncts. And then these treatments and principles, by and large, can be applied to any infection that you have, be that native spine, osteomyelitis, discitis, and epidural abscess. And I'm going to kind of give a small plug for biofilm. And I think for me, this is a huge part of what underpins my strategy for the treatment of these infections. And this is slides. These are actually from a study that I did in the recent past, looking at biofilms in infection on spine implants in vivo. And these are actually from a sheep, but what you can see is biofilm readily form on spinal hardware. They really like it. It's a lot of titanium. It's a lot of prosthetic surface. They do really well in the spine space. They grow, they multiply, they coat the hardware. There's some evidence of encapsulation if you look at these lower panels by the host immune system. There's some fibroblastic encapsulation, some strandy stuff, which is the body trying to fight back a little bit. But the biofilms almost always win to some extent. And the way this manifests with spinal hardware is really can be seen on these two sets of panels. The one in black and white is a pretty high intensity image, really looking at zooming in on what happens to the bone in the setting. And this is a sheep spine. This is not a human spine. And the panel to the right, which you can see here, is a pedicle screw, which has been sectioned to the left pedicle screw section. But if you look really carefully, you can see a lot of bony resorption and osteolysis out onto the transverse process, the undersurface of the transverse process, and then along the threads of the screw are quite loose. And if you really zoom in on this and sort of portions of E and F of this black and white figure, you can see that bony resorption, which is quite extensive. Coming over to this colored image, you can see a lot more of the soft tissue. There's a very intense inflammatory milieu which forms from these biofilms. And the reality is it is very difficult to have a clinically relevant infection, in my opinion, without bacterial biofilm in the spine space. And so for me, what does surgery look like? This could be a big surgery or a small surgery. This one happens to be a big one. It is a lot of debridement, is meticulous debridement. I do like to use methylene blue to help guide that debridement at times, which I will talk about a little bit more. I find that it helps me be more systematic, and that the blue dye helps bind and stain biofilm, as well as dead and devitalized tissue. And there's a growing body of evidence that supports that concept. But this is actually walking you through a large debridement from kind of opening up a wound that's been serially debrided to the blue staining to debridement, which is very extensive. I use the blue dye. I use a bunch of what I call kind of adjuvants or other things that I think are helpful. These are two commercially available products, of which I have no financial interest. One is a dilute chlorhexidine, the other is an iodine solution. You can use really whatever you want. I think these are helpful because of their antimicrobial properties. But at the end of the day, in a hardware-associated infection, in part because of the biofilm, I'm going to make a really controversial statement for which I would open the floor to some extent at any point in this talk, which is that you can always take out the hardware, which is so different than I think what you have been told and what we have told other people and what I was told, I think, at various points in my training. And my reasons to take out hardware are usually multifactorial, almost always. Some may call that source control, host factors. Certain organisms can be quite recalcitrant and very difficult to eradicate without taking out the implants. But really, if the implants aren't functioning, that's also another really good reason to take them out. So if they are loose, if they are not functioning as intended, there's really no point in retaining them to some extent, especially in the setting of infection, because they will just serve to further propagate that infection as soon as the antibiotics back off or the host immunity lets up even for a minute. There are a lot of really good reasons to retain hardware, which is the counterpoint to this. If it's functioning as intended, if the infection can be controlled with surgery and adjuvants, or if there's really excessive morbidity to the patient. And I'm going to talk about a couple cases here, and please, again, stop me at any time. And so this is a case, you can see this is a 67-year-old woman, really only 2 weeks after a laminectomy and posterior fusion. Unfortunately,
Jeremy.
Yes, sir.
Can I interrupt you before you start, we move on from that? So the biofilm issue, two quick questions just to set the stage maybe, or maybe you can educate me a little bit. How long does it take a biofilm to really set up or form? Meaning, is it different if I'm washing this out in the first day or two versus week? And then what about the differences in what you've used in terms of titanium or other metals or other types of implants? And you might, and we can save it if you're going to get into that in a minute.
Yeah, I mean, I think this is a great time to talk about it. So for me, I roughly follow the arthroplasty literature, so the total joint literature. That said, by no means is that absolute. The evidence really is fairly scary if you dig into it, and the biofilms probably form within hours to days, so not at 6 weeks. and a lot of that has to do with your host, and for me, a lot of these decisions are really host driven. So if your host can mount a response, if your host is not immunocompromised or otherwise functionally immunocompromised, a lot of that is what drives my decision making. I think there are materials that are better at preventing biofilm. There are certainly known antimicrobial metals in particular, like silver, but by and large, I mean, I've grown biofilm on every single spine implant biomaterial with equal success: titanium, cobalt, stainless steel, PEEK, PMMA, polycarbonate, all kinds of stuff, and it grows great. Staph, Pseudomonas, almost anything. Did that answer your question, Matt?
Yeah, absolutely.
Yeah. So this is a case, and this is an early post-op infection. So you can kind of see this is really just, unfortunately, I did want to put a few cases and I didn't want to bog you down with too many images. But this unfortunate case, this person had E. coli urosepsis while they were in a skilled nursing facility after their surgery. They developed a deep wound infection. And if you look at this T2 MRI, this is kind of a mid-sagittal cut, they developed this really interesting abscess. And this is one of the few times I've seen this, but it was distinct from the pedicle screw tracts. It was through the body of the distal vertebra. And there was this big, very T2 bright fluid collection. It enhanced avidly on MRI. And then when we explored this wound, the hardware at the distal junction was frankly loose. So it was kind of just floating in this pool of soupy pus. ESR CRP were markedly elevated. For us, our prealbumin, which is a nutritional marker that I find helpful, but by no means definitive, was at our absolute lowest value for our hospital, which is 3. And this person was obese and an insulin-dependent diabetic. There were some other patient factors for here, and that's really what pushed me here to take out some hardware. Not working a lot with PT, pain was definitely a limiting factor, and then not really participating with a healthy diet. And so this is actually somebody I ultimately ended up putting an NG tube in to get adequate nutrition, and still felt like I had to ultimately, take out that hardware. So you can kind of see some sitting films before, upright films after. This person did have a reasonable coronal plane deformity, which I think was partially addressed with their procedure. Taking the hardware out to some extent can create some instability. And so these are the things that we do start to think of. So that's kind of one case there. That was E. coli. But there are other organisms too that I find actually perhaps more challenging. I think E. coli alone without the patient factors can probably be managed to some extent. Yeah, Matt.
So sorry to keep interrupting you, but
Yeah.
so in a case like that, if you're going to go to another case, when are you thinking about re-instrumenting this patient? How long does it need to be, or are you not? What are your thoughts on that?
Yeah, so my thoughts are yes. So I am thinking about re-instrumenting this patient. I don't have a definite time point. I don't necessarily make a plan for that. I try and leave all options on the table. A lot of that's just going to be driven by the patient, kind of what happens to their deformity. I've continued to follow this patient, so you can kind of see this was an early post-operative infection. This is a relatively early post-op. We have not seen this person quite as regularly as we want. And so this decision-making is ongoing. So at some point we may instrument them, we'll follow the curve, we'll kind of see how it goes. But yes, there's a comment, and I agree that this is a big problem.
And will you biopsy before you put something back in there or not?
Yeah, I probably would. So for me, I would monitor ESR CRP are probably just my 2 go-to inflammatory markers. White count is helpful, but not necessarily terribly meaningful. I would check nutritional markers. For me, that's one of the most important things. For me, that's things like prealbumin, albumin, platelets, markers of synthetic function, and then kind of more global health status. Definitely if the patient's smoking, that's not going to happen. I really try and get this person as optimized as I absolutely can. And then from a biopsy standpoint, Matt, if there's really something to biopsy, I probably would get a new MRI with and without contrast. If there's an obvious pocket or fluid collection, I usually try and get a CT guided biopsy. If there's not, I'm also totally okay to kind of open things up. I think a frozen pathology specimen similar to joints, you could look for inflammatory cells, but I don't find that particularly helpful for me. So I think usually I'll make a decision before the surgery unless I find something truly surprising about whether to re-instrument or not. But this is a person who has not been re-instrumented and has been followed pretty carefully, and is actually doing okay, largely from the laminectomy, and their demand is moderate, and is actually getting okay with their hardware out. So I think polymicrobial infections are really another thing for me that is a real problem and a good indication to potentially remove hardware. So for me, this is somebody who was referred to me from the community for definitive management. And so they'd had a pretty substantial lumbar surgery. They'd had multiple INDs, 5 lumbar surgeries. They'd also unfortunately had a plastic surgery closure, which was in the process of failing. I took them back. I opened the wound. If you kind of look down at the distal end of this mid-sagittal CT, you'll see that these sacral screws, which are quite long, are really just floating in a soup of mush. OR cultures from my procedure were Candida, strep, and Corynebacterium, which is a really challenging combination. The addition of the fungus for me indicates that this person probably has an element of immunocompromise. And this for me got treated with removal of hardware, a really extensive debridement, and then antibiotics, which included antifungal and vancomycin. There was local antifungal that I used. I placed some amphotericin in the wound, as well as vanco and tobra powder. And this person actually got VAC to close, so I did not completely close their incision either. So this is a tough case. This guy has actually done pretty well, cleared his infection. I tried to show cases, at least for this, where they have not necessarily gotten re-instrumented. This is, again, somebody that we're continuing to follow. So these are slightly different MRI images, but you can see with and without hardware, and the fluid collections have resolved. His inflammatory markers have dropped. His functional status is better than when I met him, but it's still not quite what one would desire or what he desired prior to his index procedure. But this is not going for a home run. This is a salvage surgery. So this is a tough case. And then I think this is another kind of case that may have an element of both of the factors from that last kind of two, plus an element of probably surgery that was not done terribly well. And so this is a 62-year-old, several months. They had a lateral and a posterior surgery. They came to me on call for intractable back pain. The cause of their back pain was apparently mysterious. I was not terribly surprised by the fact that they were pretty miserable. You can see that this hardware has failed. So on the AP and lateral images, you can see the lateral cages have backed out. This person's had fracture and subsidence. All of these implants were frankly loose. And then they ended up growing enterococcus. They also had a kidney injury, which was relevant for some of our antibiotic selections later. So it made some of the IV antibiotics a little bit more difficult down the line. Taking out hardware from the back, I think is or can be challenging at times. Mostly, I think the decision to do it is what's hard. But we don't talk that much about taking out anterior or lateral implants. Fortunately, these were pretty loose and did come out pretty easily. They were frankly, could be just pulled out. But the approach in the revision setting in infection, which is something I would do myself in this case, and did do, or anterior that I could do myself or with one of my approach colleagues, that's quite tricky. And in this case, this person also did well. They have gone on to not be re-instrumented. You can kind of see the before and after. They had a small coronal plane deformity, implants in place, not really functioning as intended. That was really in part my rationale for removal, but also grossly infected. And this person has actually done pretty well. Their fractures, which you can kind of see on the last slide, in that L4 vertebral body, I think it was, have really consolidated down. And while the alignment, I think, is not ideal, again, this case for me is not trying to achieve a home run. It's trying to salvage a really bad problem. So one of the things I think I struggle a little bit is managing the competing interests of whether the hardware should stay in, if it should come out, who really drives that decision. And the thing I'd kind of tell anyone watching, particularly a trainee, is that you drive the decision on if that hardware should come out or not, because really only you as a spine surgeon, or if you're not a spine surgeon, as a spine care provider, are equipped to deal with the consequences, which are very real, from removing this hardware. You can create instability, and you can define that a number of ways. You can create kyphosis, and you could debate how big a problem that is, and that's probably been debated in this forum, and I know it has actually for a fact. Neurologic compromise for me is, I think, kind of the most absolute of those consequences, and the one that needs to be dealt with in the most expeditious and concrete way. But the patient may want hardware out. The infectious disease team may want the hardware out, the ICU team, trauma team, whoever else is involved. There's a lot of people involved in these decisions usually, but ultimately the person who would be doing the taking out is really responsible for that decision. is not a decision that should be made lightly. And I do think it really is worth trying to make every effort to retain hardware if at all possible. So this is a 74-year-old guy. He is 6 weeks out of a long segment fusion with an osteotomy, so I had a pedicle subtraction osteotomy. He did really beautifully from his procedure. This is one of my cases. Unfortunately, he did develop a deep post-operative spine infection, so went to skilled nursing facility after his procedure. Back did great. He had a total knee that got infected, and at one of his early post-op visits, I saw him, his knee was all blown up. We actually, in conjunction with one of my arthroplasty colleagues, aspirated it at that visit. That came back with Enterobacter, and then he subsequently developed some back pain, unfortunately, about a couple weeks after that. So even with appropriate antibiotic treatment and treating the knee, so the knee underwent initially an IND poly exchange, and then later, unfortunately, had to be explanted. But this back problem is a big problem. And I think determining if this patient and if you are really up to the challenge of retaining these implants, this is a project and it's a discussion. And so this gentleman, had a big surgery. He tolerated it well. He then had another surgery with his knee and then another surgery with his knee. And to get him through this, ultimately, he had 6 INDs that we did together. And I left his incision partially open with a vac to close. He has gone on to essentially clear his infection. Inflammatory markers have done well. He's done really pretty well. Is mostly limited by his knee, which is yet to be reimplanted. Was ultimately treated with vancomycin, cefepime, which has gone through this sequential suppression. In this case, the suppression and the ongoing treatment with antibiotics, which for me would probably be indefinite with doxycycline, as long as he will tolerate it, is a big part of success with this. So this is a big problem. This is a big series of surgeries. You can see what his wound looks like here. This big open hole. This is most of his thoracolumbar spine. You can kind of see where this ended up. Closed most of the incision primarily, and then augmented that. The fascia was closed. I left his skin open, multiple deep drains, and those drains did stay in for weeks. They stayed in for probably about 6 weeks until they were totally dry. A lot of the graft, unfortunately, was removed. So he's being followed pretty closely. I do make every effort to retain hardware if at all possible. He went through a lot. He has done really well from that, but it's a big series of surgeries. So this is another case, and again, stop me at any time if I'm kind of getting too into this, but this is really a full circle case. And so this is a native spine infection that went on to be a prosthetic or post-operative spine infection as well, which I think is something that personally I really dread. And I do think about any time that I do a surgery like this. So this is a 46-year-old woman, history of IV drug abuse, MRSA bacteremia, really very sick. Motor exam was 3 out of 5 strength, uppers and lowers. And you can see if you look at this T2 weighted MRI, she has a pretty big epidural abscess, also prevertebral abscess. You can kind of see off where I have the scout line. If you look up at the C2, C3 disc, there's a big pocket of pus. You can see that on the axial image. This is anterior. This is tough to get to. And this was something that we talked to ENT a lot about as part of our preoperative planning. This patient ended up going to the OR with myself and ENT. ENT helped to breed some of that prevertebral material, which was very helpful. And then I did kind of an extended ACDF and a little bit of corpectomy, mostly just removing necrotic bone. You can see the fluoro spots off to the right of the screen, and you can critique the alignment on this a little bit. I used a big piece of allograft. The facets are a little distracted, but I got a bunch of liquid pus out of there. I was able to kind of debride up behind the body a little bit, very gently, and was able to partially and substantially drain that epidural abscess to the point where, followed radiographically, that abscess up at C2, C3, C4 ultimately did clear pretty well. But despite that, this person actually had secondary and persistent bacteremia, later became obtunded, ultimately required a peg and trach. This is for some other problems which they couldn't quite figure out. Some of this may have been substance abuse related. They developed some encephalopathy. This is a pretty sick individual. And at some point in imaging of the head and neck, they saw free air on their CT. And this is kind of why I make the point of who decides to take out the hardware. And so ultimately, I said, it's not the neck, it's not a problem, it's not a problem, it's not a problem. And I did get pushed to take out the hardware on this patient. And this is in part why I say taking out hardware has consequences. And I don't know how many cases like this you're going to see where you kind of see somebody who has a case that actually looks, I think, totally acceptable. ACDF looks fine. It's single level ACDF. It's a piece of allograft. For me, that's tricortical ilium in this case, in part because of what happened next. And I ended up taking out that plate. I think at the right time, it was the clinical decision that needed to be made to remove that hardware. But you can look, and this patient pretty quickly falls into kyphosis, even beyond what they already had. If you look at these pictures critically, you can see that this patient has breathing in nutritional adjuncts, initially NG tube, later a trach. and this progresses, and this kyphosis progresses. That graft goes on to fragment and collapse a little bit off to the right. Is that patient's alignment ideal? No, absolutely not. I mean, is this what I wanted for this individual? But the really amazing thing is she is completely asymptomatic. She is totally neurointact. She has 5 out of 5 strength. And this is getting her through a really bad problem in a way that is really designed to minimize morbidity and maximize her ability to clear that infection. So I think, again, this is kind of salvaging a bad case. There was a question about use of graft, allograft, autograft. I think in this case, you can make a case for either. I think in a sick patient, I think autograft may have been a better choice to address Dr. Berchuk's question. But this, for a variety of kind of patient-related reasons at this time, I did not elect to use iliac crest. And then I did use tricortical ilium. You could use a different kind of structural graft, be that fibular, machined allograft. I think for me, use of a titanium interbody in this case, PEEK or something else, would not have allowed me to do what I subsequently did, where I took the plate off and then could watch this. So the use of allograft or autograft, structural graft in this case, I think is in part what allowed me to do this and to get a good result for this individual. But this is controversial stuff. To kind of take this concept a little bit further, what I would tell you is that sometimes the best idea is really not putting in hardware at all. And so you may have a patient who's had infections in the past, and how do you go on to get them a good result with a degenerative problem? So this is an individual, older, reasonably healthy, but had quite a few medical problems, who had just absolutely crushing stenosis. You can look at the CT myelogram off to the left. They'd had a number of different recurrent infections in the past, including total joint infections, numerous soft tissue infections, some urinary issues. I think they had a prior prostate surgery. And so ultimately, this, to me, pushed this individual away probably from an instrumented fusion. We talked about laminectomy alone. Ultimately, this patient's stenosis was severe enough that I did remove a lot of facet. I removed a lot of pars, generated a lot of local bone in the process, and did elect to do an uninstrumented fusion. This is what I call a longer segment uninstrumented fusion from L1. This person really got fused L1 to S1, kind of all said and done, with local bone, a little bit of allograft and BMP. And you can see that AP, the post-operative AP, which is about a year out, you can see a really robust posterolateral fusion mass. I did put this patient in a brace after, which I think was helpful, but not totally necessary. And then at about 2 years, you can see there's a CT scan, just kind of showing that posterolateral fusion mass. That's a parasagittal CT, just kind of showing that we actually were able to get this to fuse pretty robustly in at an anticipated time frame without hardware. And I think it's important to remember that this is how fusion was done in the spine for a long time. We've had screws now for quite a period of time, polyaxial hardware, again, for decades. So this is a little bit of a look back at the historical nature of our profession, but it's a very important thing, I think, to keep in one's toolkit. This is not something I do all the time. I'm not doing a ton of onlay fusion. But I think for a case like this, where this patient has a large risk of infection, minimizing the amount of foreign material for me and using the vascularity and the pro-inflammatory response of the BMP is very helpful in getting this person a good result. And they have not had an infectious problem. They've gone on to do just fine from this procedure, and I continue to follow them.
So for those of us, obviously a lot of us do that, right? But lots of people did in previous times. Just out of curiosity, how much BMP did you use? What did you do post-operatively? Did you put them in a brace, or how did that to work?
Yeah, Matt, those are great questions. So this person, I use local bone, little bit of bulk allograft. This person had a single large kit of BMP. So for me, I felt that dose was totally fine. And then I did put them, I think, in just an LSO. So relatively minimal bracing. And, if you look at the data, the brace doesn't do much. It's a nice idea. And I think it's a nice reminder as a kinesthetic reminder to the patient. But it doesn't do that much more. And LSO doesn't do that much more for lumbar or, thoracolumbar or lumbar sacral motion. But yeah, I mean, you could use autograft, you could use ICBG. I had just a ton of local bone on this case, and I didn't feel that the morbidity of iliac crest. But I also have one of my partners who will routinely use large amounts of ICBG for this exact problem, with or without BMP, and has a really good result from that also. So I kind of touched on it, some of these tips and tricks, and the blue dye I did mention is one of particular interest of mine. I think it is helpful as a visual aid to guide debridement. It is not magic. This is blue dye in blue water that can be squirted on your spine wound. It can be done so very safely. It will stain biofilm. There's good evidence of this in the orthopedic and neurosurgery literature. There's good evidence that it will stain dead and devitalized and necrotic tissue as well, which to me are the primary things that I would like to remove from a wound. You can kind of see this in an actual wound, and the blue dye does stain dead, devitalized, and infected material, both in a wound bed, but also on implants. And so this is a study that I referenced earlier looking at sheep, but it does kind of support this concept. Antibiotics are very essential to this whole process. So work best, I think, when culture specific. So if you can get blood cultures that point you in the right direction, if you can get a CT guided biopsy for a problem infection, any additional information I think is super helpful for this. But there's really no role for oral antibiotics alone. I don't use them a lot. If somebody has a superficial infection, I'll mostly do local wound care. But beyond that, IV antibiotics and then in-wound antibiotic for me is adjunct only. There's a bunch of different ways to do this. For me, mostly I'm using vancomycin, tobramycin, not gentamicin so much, but you can. Amphotericin, voriconazole are nice antifungals. For me, mostly amphotericin, depending on the organism that I'm worried about. If there's fungus, usually I think you're going to know about it prior to a definitive debridement, but not necessarily so. You can add this stuff to PMMA beads. I went through a phase a couple of years ago where I liked the beads because I felt like they made space. And I've moved away from that in part because you mostly need to take them out. You can leave them in forever, but I worry that same as a metallic implant, this is something that bacteria will grow on and then can reseed infections. So I've moved away from PMMA. Similarly, calcium sulfate, I actually don't think is a great solution either. There's some emerging literature that the bacteria actually will kind of grow on the calcium sulfate also, similar to PMMA. Sure, it will bioabsorb at some point. It does take a while. Also has a lot of osmotic load. So I think your wound's a little bit more at risk with calcium sulfate, with antibiotic, with BMP. All those substances are very osmotically active, so we'll just draw in tons and tons and tons of fluid. For me, if I'm going to use any of that stuff, I definitely will use a vac in some capacity. That could be an open vac, that could be fascia closed, skin open vac, that could be an incisional vac. BMP I referenced earlier, I think this is a really nice adjunct. This is off-label use for BMP. The data on this is a little bit unclear, but it's thought to sort of increase vascularity in this pro-inflammatory milieu. Post-infectious beds for fusion are not ideal places for healing, for bony healing. And it does definitely seem to enhance healing, enhance vascularity, and increase fusion in a relatively hostile environment. Vacs and drains, I talked about a little bit. I'm a huge fan of VACs. This could be a real VAC that you use in any capacity. So open incision, fascia closed, skin open, open. You can use a big VAC, you can use a little VAC, you can use a Pico, you can use a Previna. There's a lot of different iterations and incarnations of these, but I think they are very helpful for wound management, and I'm a big fan. I use drains, lots of them, and for a long time. And then this is kind of another piece, which is I think it is very important to have a friend with these cases. I think these cases are not necessarily fun. I think these are great cases to be done at a tertiary center. I think they are good cases to be done by somebody experienced with this problem, not necessarily the lowest person on the list who just started 6 months ago and maybe in their board collection period. I think an experienced hand is very helpful for treating these. A plastic surgeon and either local or free tissue, but mostly local tissue advancement can be super helpful in managing and dealing with these tissues. They tend to get very stiff. They're not very pliable after even a single debridement, but certainly after multiple debridements. There's a lot of local tissue advancement that can be done. You can rotate muscle flaps to cover. But in particular, the plastic surgeon that I work very closely with, we call him the pizza man in a bad joke because he delivers, but the pizza man has rules, and he will essentially insist that our patient is infection free, which is sometimes a really tough ask, that they have adequate nutrition, which is again, sometimes a tough ask, especially if you're trying to heal a big wound or a big problem infection. I will place NG tubes. I will place PEG tubes. These are really pretty substantial measures that I will go to get these wounds to heal, because it's just so essential to get rid of these infections. All these patients for me, while they're inpatient, are on a special diet, which is high protein with multivitamin, additional vitamin supplementation, and some arginine. The data is a little bit mixed, but this has been working pretty well in our institution. Plastic surgery coverage tends to be definitive, so we will kind of involve the plastic surgeons when we're really no planned additional procedures. And then techniques and your partner with this will really vary. And it's a discussion of what your goals are for surgery, what your goal is for salvage. With these cases, I would never be afraid to transfer them to a tertiary center. I think if you're going to do that, I would really recommend making a phone call to somebody. These are not nice cases just to send and have show up to one of your tertiary centers. And I think it definitely will facilitate better care of your patient if you're transferring these people to make a phone call to the accepting spine surgeon on call, or to somebody you know who is willing to tackle something like this. I kind of jumped to taking out the hardware earlier, and by no means did I want to give the impression that that's the standard treatment for this, but I thought it was a great topic for a case conversation. It's really a last resort, and if all else fails, you can take out the hardware. It's okay to do. And I think you should remember that it is part of your arsenal, and I think you can still get your patients a good result, while doing that. So I would, appreciate any questions or discussion. I'm happy to revisit these cases. My take-home messages for this are really that treatment of these post-operative and problem infections is diagnosis specific, depending on the organism and the host. A lot of these problems are not necessarily organism problems. There's a lot of biology that needs to be addressed. That the host environment is absolutely critical to success. Antibiotics alone are really never an option for me just for this, because they just won't work in the presence of biofilm. There's cells in those biofilms that will outlast any amount of antibiotic indefinitely. And I think you have to define what success looks like in a case that is maybe not going to be a home run. And I think then you have to probably do what's necessary to achieve that treatment objective. But that's definitely where shared decision-making happens between you, the patient, patient's family, who's critical in supporting this process, as well as other team members and stakeholders. So I'll probably pause there if that's okay, Matt, and kind of open the floor back up.
Yeah, it's perfect. That's fantastic. The one question that I have, well, one clarification, one question. The clarification is, you said earlier, no role of oral alone, and were you saying no role of oral without debridement, or are you saying no role of oral without first undergoing IV treatment?
Yeah. Well, so no. So I love oral antibiotics as an adjuvant. So you treat lots of tumors, right, Matt? You do. I
Yep.
think of spine infection the way you probably think about spine tumors. And if you look at the data, I mean, the reality is their outcomes are not that different. So I think you have to kind of almost view an oral antibiotic as an adjuvant to follow, chemotherapy. For my patients, if I really think they're infected, if I really think that they have a deep infection, I think giving them 10 days of Bactrim is not the solution to their problem. So I
Yeah,
think accepting that you have a problem is often the first step. You say that in everything, right? Like accepting that you have a problem is the first step to whatever happens after that. But I'm not going to use a lot of oral antibiotic in anyone that I think is actually having a deep spine infection problem alone.
yeah, I understood. The thing I've run into a couple of times is, and it's only in the last couple of years, really in the last 2 years, I think that I've had this, is occasionally we'll be in one of these positions and ID will say, well, the bioavailability is the same.
Yeah.
So they should go on oral.
I mean, I don't know how to argue with that. Do you?
Well, I haven't. I mean, I'm like you. I'm like, well, I guess if you're telling me it's the same delivery, then that's that. But I guess I don't know that that's always true.
Yeah, I mean, I think commonly, like a lot of these options are targeting different organisms, perhaps in different ways. So I think it really depends on your class of bug and drug.
The other thing I want to get your opinion on is, so, and you mentioned it, you touched on it, but I'm going to push you a little bit. The Sorry about that. The chronic suppression. So I don't know that I certainly have patients that are on chronic suppression. I don't know that I fully understand it. And I've had a few that I can think of one or two specifically that just stopped taking their chronic suppression because they didn't want to, and they seem to do fine
Yeah.
with retained hardware. And now this is months later. And so in those patients, are they, um, you know, is it that they still have the infection and they still have a biofilm and it's just brewing, and it could be a problem at any point in their life? Or are there patients that might have cleared everything in those cases? Yeah, I don't know that I understand that.
I don't know that I fully understand that either, Matt. I mean, I think these biofilms are very fastidious. I think that they are difficult to eradicate. Their true eradication for a lot of them is mechanical debridement with these drugs as an adjunct. So your goal is to try and break up. There's like protective slime over them. There's different phenotypes of the bug within the biofilm. Some are more or less virulent, which means that they're dividing more or less rapidly. The more active that infection is, actually, the better the antibiotics work. The more kind of indolent that infection is, the more problematic. That's part of why things like C. acnes are really challenging to get rid of. So C. acnes makes biofilm. It's very slow. It's anaerobic. It makes a really nice slimy space and can last for years. And in shoulder patients and pediatric scoliosis and adult patients, I mean, it'll turn up. Are those bugs there? Do they outlast? I don't know. Chronic suppression is tricky. The data is swinging a little bit. People are moving a little bit less away from indefinite suppression for total joints. That pendulum is definitely swinging. So I don't have a great answer.
Moving less away, you said.
Yeah, it's moving a little bit. It's moving a little bit away from indefinite suppression to things like 3 months or a year, and then giving them a
Yep.
holiday, kind of seeing what happens. So I ask for, for these folks, I ask for indefinite, knowing full well that will not actually happen. They will have a drug reaction. They will have an insurance change. They will stop taking them. I don't particularly, I wouldn't want to take doxycycline for the rest of my life.
Yep.
I'd probably say,
Yep.
I'll take it for a year and see what happens.
Yeah, I mean, one of the ones I'm thinking of is a very reasonable guy that had a primary tumor in his young, and he kind of was like, I don't know, I don't want to be on it. I seem to do fine. And I just kind of told him, like, I don't actually know what that means. I don't know if that means you have something brewing or not. I mean, he kind of already did it himself and has been doing fine for a long time now. So I don't know what to tell people. I don't know if this guy has some biofilm waiting to rear its ugly head, or if he's fine.
Yeah, and he may, and the reality is, Matt, like if you look at the data for, if you look at kind of next gen sequencing and sequencing of any kind, including PCR, of aseptic revisions, I mean, there's bacteria that you find. Is that bacteria alive or dead? You can't necessarily tell, but we live in this perpetual state of equilibrium with bacteria in our skin and elsewhere in our bodies. And so I think there are bugs there. Some are probably better for us than others. And that's why the host factor is so important to this.
One of the things we have in the tumor world is slow to heal wounds, radiated skin, things like that. Do you do a lot of not in the setting of infection already, but in prevention, a lot of incisional vacs, particularly someone that might be radiated and it might be a lumbosacral wound, to kind of seal it off? And if so, how long do you leave it for, and that sort of thing?
I love incisional vacs. I think the residents that I work with love that I love incisional vacs, because I put them on in the OR and they stay on until that patient is mostly ready to discharge. And we have a really nice wound care team that will change them every couple of days for us while they're inpatient. So in tumors, 100% of those wounds, if they're posterior, get an incisional vac. I have placed a couple, actually, Matt, anterior incisional vacs. I actually just took one off today, and those work great too. Those cases, your tumor cases, I definitely think are really good candidates for primary plastic surgery closure also, which I didn't talk about directly, but kind of alluded to. I think for me, those are one of the only indications where I'm going to use primary plastic surgery closure for like a primary case where there's good tissue excursion and things like that.
And then when you, so yeah, where I trained originally, I think we would leave these on for 3 days and then look at them and decide keep going or not. And then in working on these cases with plastic surgeons, they seem to do what you do. They leave them on longer. Sometimes they leave them on for a week or two before they look at them.
Oh yeah. I mean, my eyes don't have healing powers. I wish they did. So I trust that I put it on in a sterile environment. I monitor the patient. I monitor them clinically. I try to look at that wound as little as possible while they're in the hospital, because I view that as an opportunity for contamination. And then I'll change it, when I need to, but I'll leave those wounds on until day of discharge, or the vacs on until day of discharge, if at all possible. Because that big sheet of plastic, keeps that person from peeing on that wound, pooping on that wound, vomiting, whatever else is cooking in the hospital. I think it's just better on the inside.
And you'll send them home with it, or not typically?
At times, yeah. I have some logistical constraints in some of my practice environments where I cannot discharge patients with vacs. Yep. But in some of my practice environments, I can. So if I have an opportunity to send somebody home with a Pico or a Provena, I often will change it day of discharge, make sure the wound still looks good, and then send them out with that mini vac, and then they will self DC that over the next 5 days or so.
If anyone has a question, feel free to jump in. I think Selby's on here as well. I'll ask one more because I'm just, because we got you on the hook here and I want to get all I can out of you. Case I'm dealing with now is from an outside shop that's got an infection and has an inner body. I guess my thought now is that the inner body is staying. It's a very small, it's a smaller case. I think it's L3 to 5. It's the inner body's kind of integrated in there a little bit. I think right now the plan is that the metal from the back's coming out, the inner body's probably staying. Sounds like from what I'm hearing from you, you would advocate for, if at all possible, to get that thing out. Am I hearing that correctly?
I think it really depends on if it's working. So if that, when that case was done, is this an old spine surgery with a new infection? I mean, it really depends. If that inner body is working and if it's really osteointegrated, it depends a little bit what the material is. What's it made out of?
I think it's titanium, and it's a little bit of a tweener. It's not that old of a surgery. It doesn't look like it's super well integrated. It's not, you know what I mean? Like, it looks like one of those things where you're like, well, I think there's some bridging stuff, but it doesn't look awesome.
Okay. I think it's really just a judgment call. I mean, I think if you should come out, or if you think it should come out and you can get it out safely and easily, let's say you could take it out from the front and handle it that way, I think it's probably better to take it out. I think if you can't get it out, I think it changes how you're going to manage that case a little bit. I think there's a question that I sort of wonder, well, like the posterior hardware is infected, is the anterior space really infected? I don't really know an answer to that. I would say sometimes yes, sometimes probably no, especially if that's like a new infection in an old mature fusion. Peak implants are okay. They are what they are. One of my favorite parts about them is you can just burr them out. So that's really nice. The titanium, not so much.
That's right.
So I don't know if that helped you.
Yep. Yep.
Hey, Matt. Hey, Jeremy. Mike Selby. How are you?
Hi, good. How are you?
I'm good. I'm good. Hey, sorry I'm a little late today. I was having a look at a patient with a draining incision, ironically, but just getting something sorted out. But I suppose I got a question for you. If you've got a patient, and this happened to me sort of in the last 2 years, unfortunately, once, you've got a patient who you suspect might be infected chronically. It's a revision situation. I went into this guy, everything from T11 to S1 was loose. I cultured everything. We didn't give him antibiotics before incision, and nothing grew. Then I went back, and he did have a slightly elevated CRP ESR. And then I went back and did his revision surgery. And after his revision PSO, he came up with an infection.
Yeah.
So have you got any tips for that situation? Like, are there any advanced testing that I can do? Because this guy had also had a chronic knee arthroplasty infection previously. And I think he was predisposed to all this stuff. And I bet he was infected why all his metalwork got loose in the first place. But I just couldn't get a diagnosis out of that space around the spine. Are there any new things that I should be doing in that situation?
Yeah, Mike, that's a great case, and a really, I probably should have showed a case like that for this as well, because it's a little bit of a different flavor of infection. It's kind of chronic, indolent, but problematic infection. Things like C. acnes very commonly will do exactly what you're describing. So C. acnes is an anaerobic organism found in the skin, very prevalent in the back and around the shoulder, tough to culture. So things like PCR, if your institution will do that, can be very helpful. You can, if you're going to pull implants, you can sonicate and send for PCR. So that's something I've started doing more. Even holding cultures longer. So C. acnes is very slow to grow, requires anaerobic conditions and anaerobic handling. And so one problem is like on a swab, usually that's actually an aerobic environment. So C. acnes will not grow particularly well and can't even die on a swab. It's not particularly fastidious out in the open. But if you're able to keep it in a piece of tissue, and so especially for these revision cases, usually I'm going to send a bone culture, usually multiple. So I essentially take an open biopsy of bone. I usually send some soft tissue also, but in particular, I think that kind of superficial bone culture that's in and around the hardware, for me, has been very effective at turning up things like C. acnes and other less virulent organisms on the cultures. I don't know if that helps.
That helps a lot, Jeremy. Thank you, mate. I think, and the other thing you said was sonicating. So is that like just getting the implants sort of really just washed off and sending all that stuff? Is that what you do for that?
Yes, sir. So exactly. So I take all the implants, they essentially go in a big pile. Our lab will essentially then kind of aggregate them. They put them in a bath to sonicate, which uses ultrasonic frequencies to help loosen material on that. And then they can do a couple of different things with it. You can spin it down and kind of get some material out of it, which you can culture. You could also send it for PCR, which is just essentially sequencing and then comparing that to a database to kind of see what you turn up. So they're kind of different modalities that try and achieve the same goal. I think the conventional culture methods tend to be a little faster. But I'm usually going to hold most of my cultures for 14 days, which unfortunately for me is also a special request.
We have a little chat here, a question about new innovations in the future for infections, whether there's a role for bacteriophages or implantable antibiotic delivery devices, for example.
Yeah, those are great questions. There was some talk about bacteriophages at MSIS this year. That technology, as far as I can tell, is definitely a little ways away. I don't really envision my patients with bacterial infections clamoring for viral infections at the same time. So I think there's definitely going to be an issue from a patient-facing standpoint with that. But I think the technology is definitely evolving, and I think it's a lot closer to production than it was 5 or 10 years ago. And I think is really, it's definitely a hot area of research and very exciting. And I think could be coming. That's probably 5, 10 years or more down the line. There are some implantable antibiotic delivery devices that I think are much nearer to market. FDA in the US in particular, this is a global forum, but FDA in particular in the US is really problematic for these devices because they're hard to classify. So they have a little bit of a tricky path through the FDA depending on how you're going to use them. If they make it through the FDA, you can kind of use them for whatever you want in an off-label capacity, as long as you think they'll help your patient and you're not getting paid to do it. But the reality is some of these devices that are specific to this are not quite there. So there are a number of implantable, and I would say infusible and perfusible devices. Some of those I would differentiate infusion and perfusion. Infusion, where you're kind of instilling an antimicrobial solution, and then perfusible, where you're both instilling and removing solution. There are some devices that are kind of looming in the market. These things can be done in a fairly rudimentary fashion. It's been described by people like Leo Whitesides for arthroplasty applications a number of years ago. But this is kind of the next evolution of devices that achieves a similar goal. And that could be with an antimicrobial solution. It could be with antibiotic solution, almost anything you want.
Well, Jeremy, this has been fantastic. It looks like we only have another minute or two here. So if there's no other questions, I don't see any more in the chat. I think we can wrap it up. Thank you for a great talk. And I feel like every time I hear you talk about this, I learn something new and can reflect back on something I should be changing or adjusting a little bit. So thank you for that. And I think with that, we can probably end for tonight, unless there's anything else you'd like to add.
Thanks again, Matt. Really appreciate the opportunity, and thank you all for joining and participating. This was great.
Well, really great talk. Thanks, Jeremy, and thanks everyone for attending.